Dr. Neha?
Yes, sir.
We should start now.
Yes, okay, ma'am.
Dr. Uma, we are starting.
Sure, no problem.
Okay.
Good evening, everyone. I welcome you on behalf of Ratlam ROGS Meeting Society for this webinar with a very eminent speaker. I hope you'll enjoy this and cherish the session a lot. To start the session, I request our President, Dr. Manisha Maheshwari ma'am, to give her welcome.
Thank you, Dr. Neha. Greetings and good evening to all. It's my pleasure to invite and welcome our eminent esteemed speaker, Dr. Uma Ram ma'am from Chennai. She will be delivering a lecture on Rh negative pregnancy and its management. It is my proud privilege to welcome Dr. Nilesh Dalal sir, who is my teacher, to chair this session. He is professor and HOD Obs Gynae Department, MGM Medical College, MY Hospital, Indore. I invite and extend warm welcome to all the seniors and colleagues of Ratlam Obstetric and Gynec Society, and also welcome all the other participants of this virtual meet. I would like to give a brief introduction of Dr. Nilesh Dalal sir, who is present HOD and Professor MGM Medical College MY Hospital Indore. He is President of Indore OBGYN Society. Sir was meritorious student and gold medalist throughout his MBBS. He has done his MS in 1990 and have been national faculty at all the AICOGs since 1993. He has 28 years of UG, PG teaching experience, worked in Tata Cancer and Nair Hospital, Mumbai, have many awards to his credit like CS Dawn Award for the best paper presentation and Pfizer's Award for MCH services in MP. He has many publications and contributed chapters in more than 10 books, has chaired many national international conferences. He was superintendent and in charge of Kalyanmal and MTH Hospital Indore. He has special interest in imaging, oncology, male infertility, and critical care in obstetrics. I welcome you, sir, to chair this session. I call upon Dr. Neha to carry on the session forward.
Thank you, ma'am. I request Dr. Nilesh Dalal sir. First of all, I would like to thank you, sir, for sparing time and accepting our invitation to be at Ratlam. I request you to enlighten us with a few words of wisdom of yours and invite our speaker for the talk.
Good afternoon, everyone. It's a homecoming. Ratlam Obstetric Gynec Society is a very integral and a close society with me. And for MPOX, I welcome Dr. Uma Ram. We have not yet met, but virtually we have seen each other for one of the programs. Manisha has been one of my very favorite students in my department when I was associate professor and professor. Rh negative, we all know, is very important. Hydrops, fetalis, important cause of neonatal morbidity and mortality. And there are adjunct problems with the maternal complications also, like polyhydramnion, preeclampsia, problems with induction of patients, problems with how much the dose should be administered, and what complications can occur to an Rh mother and the newborn. But recently with NTD and all, Uma will also agree that with prophylaxis antenatally and postnatally, the complications have reduced, which we used to see when Chaparwal sir was here as the head of the department, Manisha's father in pediatrics, when we had all babies having hydrops and the third stage, what I should say, the complications of neonate. But still we have perinatal morbidity and mortality significantly. And this webinar will bring an insight in the important topic, how well we should manage such critical patients, such abnormal pregnancies in terms of the blood group and the what I should say, the maternal-fetal hemorrhage and the leak. Thank you very much. May I have a slide of Dr. Uma for the CV?
Yes, sir. Mr. Arjun?
Share the slide, please. Dr. Uma Ram, as you know well, like Manisha had introduced, she's from Chennai, and she has a special interest in critical care, the discussions on the hydrops and RH problems of fetal medicine. Fetal medicine, as we know, last a decade or so, has come up as a subspecialty of obstetrics, and a lot of people have refined themselves in this field, putting a lot of their knowledge, insight in terms of decreasing perinatal morbidity and mortality. So we should listen to her. We may have the slide, sharing of slide that time also.
Yes, sir. Dr. Neha is requesting the person.
Okay.
That's okay. I think
I have introduced, but your credentials, what else I was.
Yeah, no, that's okay, sir. No problem.
Okay.
Yeah.
We'll share it in between.
So,
No problem.
we'll go ahead.
We can start with the slide.
Yeah.
I've told my postgraduates, all of them to join, but the emergency duty is also on. But they're
Yes, sir.
They're joining in.
Mhm.
So thank you very much for asking me to be a part of your CME and program. It's always a pleasure to interact with people. Unfortunately, thanks to COVID, we are not able to see each other face to face. But I think it's also giving us opportunity to reach out to a lot of places where it may not have been possible to go, at short notice. So I think we have to focus on the positives. So thank you very much, Maheshwari, for inviting me. And over the next maybe 40 minutes, we'll talk about Rh negative pregnancies. And I'm open to questions which we can take in the end. So if we want to, just to begin to ask ourselves, what is the prevalence of Rh negative pregnancies? It varies depending on which part of the world you're in. And in India, it varies from about 5 to 10%. Obviously, compared to maybe a decade ago, certainly the burden of Rh disease has reduced, but it has in no way disappeared. Because unfortunately, even though anti-D is readily available, we still see a lot of Rh disease and isoimmunization and sometimes fairly sick babies who get referred largely from the periphery, but occasionally even in the metros. So this is something that is entirely preventable, and therefore it is important for us to understand and ensure that we are able to eradicate this condition. The prevalence of isoimmunization per se, of course, is less, and it is stated to be 1 to 2% worldwide. Again, in many of the Western countries, the burden of Rh isoimmunization has come down significantly, but in other parts of the world, it is still quite prevalent. Now, we must remember that though we think only of the D antigen when we talk about Rh disease, there are about 48 different types of antigens in the Rh system. And therefore, sometimes we may be caught by surprise, even though we think we have taken all the necessary steps going forward. So this is a table that I took out from UpToDate, which basically talks about the frequency of the Rh haplotype based on ethnicity. Of course, this is from the United States, but you can see that in Asians, majority of us have the D, C, and E. The small d does not induce an antigen. So we don't see much of the non-D antigens in the Asian group. So when we generally say Rh negative, what we mean is that there isn't a D antigen. So these women may sometimes have C, small c, or E and small e antibodies if they are exposed to fetal RBCs which have the C, small c, or E antigen. right? Or if the woman has inherited the antigen from the father and it is an antigen that she does not share. So when we prophylax with anti-D immunoglobulin, we are prophylaxing against the D antigen mediated isoimmunization. However, you can't prevent C alloimmunization. So this is reason why sometimes we find women who actually say they got anti-D, but we are seeing isoimmunization impact on the fetus in pregnancy, and we are wondering what could have caused this problem, right? So that is just the basics. So you will realize that what are these antigens that we are talking about? These are antigens that are both protein as well as sugars, which are integrally linked with the membrane cell membrane, both protein and lipid. And these antigens have the ability to incite an immune response and create antibodies. And this is what makes them clinically relevant, both for tissue component transfusion and for tissue or organ transplantation. So let's begin with a few case-based discussions. So this is a 28-year-old who is booked for her antenatal care, and she's had a previous normal delivery. Now, I don't know if some of you have faced this problem, but I'm sure some of you have, if not all. So you have somebody who has a booking blood group that says O negative, but then you have a previous pregnancy report that says O positive. So the couple, before they come to you, decide to go, they want to test because, how is this possible? And they realize that, negative blood group has certain implications in pregnancy. They go to have a test, and one lab says, blood bank says positive and other lab says negative. So what do you think is happening here? So you have individuals whose red blood cells are tested with an antigen, then or an anti-D reagent. They may not show a reaction, or they show a reaction which is less than 2+. But when it is tested with an anti-human globulin, you can get a moderate to strong reaction. So this is the reason, because of the nature of the antigen with which they are tested, and because the response is weak, you may see a discrepancy with one lab calling it positive and one lab calling it negative. In general, in a blood bank, because they go through all the steps, you may have these people classified as positive, whereas in a generic lab, they may not be classified as positive. So these individuals are called a serologically weak D positive groups. And in this, there are two categories of people. Those who have a decreased number of intact Rh antigens on the surface of the red blood cells, what we call the weak D type. And there are some in whom the Rhd antigen is missing a portion called what are called epitopes, and these are the partial D phenotypes. So I'm just making this point for us all to understand that something as basic as a blood group needs to be treated with a great degree of respect, and it needs to be done in a standardized lab. And if you find a discrepancy, don't just say, oh, that lab may not be good. Check if there is actually a reason why the Rh can be reported differently in two different labs. So for all practical purposes, these women, it is recommended that we ideally do the Rhd genotyping for the weak D types. And if they have type 1, type 2, or type 3, considered to be Rhd positive, and you do not need to give the anti-D immunoglobulin. However, if the types 1, 2, and 3 are not found, then you manage them as Rhd negative. Now, this is what is considered to be the fact. But however, in real life, it's very difficult for all of us to get Rhd genotyping done on our patients. And therefore, it is safer to err on the side of caution. Consider them to be Rh negative, irrespective, because if we can't get the genotype, administer the anti-D, because we cannot do any harm by administering anti-D, whereas we can potentially induce an alloimmunization if she is not a type 1, type 2, or type 3. I hope I'm making that clear. And this was now, there are two ways of looking at it. The way I looked at it is from the individual level. If you look at it from a larger national level or a health economics level, then this is from the US, where they stress the importance of doing the genotype, because they say that if you do the genotype and identify these three subtypes where you don't need to give anti-D, then almost 25,000 units of anti-D immunoglobulin can be saved from being administered, and you can save Rh negative blood being given to these women, and all of this will have an impact over the broad health economic situation when you're talking of a country. So now with that background, moving on to a woman who books for her antenatal care. Her blood group is A negative. All her other booking blood tests are normal. Her BMI is 22. She has no allergies, no medical problems. She's 6 weeks from her last menstrual period. Now, in view of her Rhesus status, how should we plan her pregnancy? So in generally in a primip, we are not terribly worried about isoimmunization developing and the baby being affected. However, when we take a history, we must take a detailed history to ensure that there has not been any blood or blood product transfusion in the past, because even though it is her first pregnancy, if she has had a transfusion, and unfortunately the transfusion has not been cross-matched and screened, she could have already developed antibodies which will impact this pregnancy. Now, if she presents at 7 weeks with spotting, what should we do? Should we give? So we all know that bleeding in pregnancy is a sensitizing event. So the question is, at 7 weeks, if somebody presents with spotting and we know that they are Rh negative, should we give anti-D or not? The consensus is that before 12 weeks, if there is painless vaginal bleeding or a complete miscarriage where you have not done anything, you have not given her medication, you have not given her done a surgical evacuation, then the prophylactic anti-D is not necessary, because the risk of feto-maternal hemorrhage and resulting exposure of the mother to the anti-D is negligible. This is from the RCOG guidance. And so you could, in very early pregnancies where there is just slight spotting or a confirmed complete miscarriage has happened, not necessary to give anti-D. But again, here we would err on the side of caution and administer it, because you don't want to miss the opportunity to prevent an alloimmunization. Now, what are the things that we should check before we administer anti-D? We need to identify and make sure that the woman his name is correct and the tag is correct, that her blood group has been appropriately documented, and we have a look of the document. There are many women who come and tell you that they belong to a certain blood group. They may not have a record with them, and we just take them at face value and put it down. Sometimes we are caught, actually, it's not a good kind of surprise, a bad kind of surprise, when we find out that actually their blood group was completely different from what they thought they had. So it's important to identify the blood group, to know that what the immune status is, that she's not somebody who already has antibodies to the Rh. And before giving anti-D, we need to get informed consent and have the woman sign off on the fact that the anti-D has been given. Now, the early pregnancy situations where we definitely will give anti-D, and this is from the British Hematological Society guidance, as well as the SOGC and the US guidance, is that any vaginal bleeding with severe pain in an Rh negative woman, anybody who has a surgical evacuation, if there's an ectopic and in a molar pregnancy, you would give anti-D. Now, all the guidances will say that the recommended dosage is 250 international units or 100 microgram dose if we are talking the first and early second trimester, and 500 IU or 300 microgram dose in the late second trimester and third trimester. However, for many of us, this smaller 100 microgram dose is not available, and therefore we end up giving the standard dose for everybody. So let's say she undergoes first trimester screening and has a risk of 1 in 110. And after counseling, she opts to have an amniocentesis. Now, in this case, what are the precautions that we should take? Now, if she needs an invasive testing, any invasive test in a woman who is Rh negative warrants anti-D prophylaxis. And again, the question is how far away. So if you have not given her anti-D when she came in spotting, then definitely you need to cover her with anti-D for the procedure. If she has come in with spotting at say 7 to 8 weeks, and you somebody who has given her the anti-D and you've given her the 100 microgram dose, then at 12 to 13 weeks, that is, you probably would cover her with anti-D again. Now, if after getting the prophylaxis for her amniocentesis at about 14 weeks, what happens if she presents at 18 weeks with bleeding? So let's assume that at 7 weeks, when she has come in spotting, we have not given her an anti-D. She comes for her amniocentesis, and at 16 weeks, she's opted for an amniocentesis. And at 16 weeks, she's had an amnio and she's had anti-D. 2 weeks later, she comes back with some spotting. What do? Do we need to give her anti-D? To answer that question, we need to know how long the effect of one shot of anti-D lasts and what is the half-life. So in general, the recommendation is that we don't repeat an anti-D unless 6 weeks have lapsed from the previous anti-D. The exception to this rule is if there is a massive or a significant fetal-maternal hemorrhage. If there is a significant fetal-maternal hemorrhage and you're still within the 6 weeks of having given her anti-D for say another previous episode of bleeding or a procedure, then the recommendations are that we do a CLIHO, check how much fetal-maternal hemorrhage actually has happened, and then titrate to see whether she needs an additional dose of anti-D or not. Again, here, in my opinion, the rate limiting step is the presence of a lab which has the ability to do a Kleihor-Betke. Now, in many places, Kleihor-Betke is not available. I don't know whether it's available or not in your town, but certainly in Chennai, there's exactly one lab which will do it if we request. So we sometimes are not able to follow the protocol and give the appropriate dosing of anti-D, even though we know that a fetal-maternal hemorrhage has happened. Now, she comes in spontaneous labor and delivers vaginally. Now, at this point, obviously, the dose of, we would check the baby's blood group, and if the baby is Rh positive, then we give her the full dose of anti-D, which is 500 IU or 300 micrograms. Now, what happens about antenatal anti-D? Because I've only spoken about anti-D in the context of a sensitizing event. I'm not sure how many of you routinely use antenatal anti-D. Now, the postnatal dose does not vary with the dose of antenatal anti-D that is given. And the Kleihor-Betke I already spoke about, because that is a test to determine fetal-maternal hemorrhage is useful when by doing acid elution to know how much of anti-D is to be given so that we don't underestimate the fetal-maternal hemorrhage and underdose the anti-D that we are doing. Now, antenatal anti-D, single and 2 doses, both have been recommended in literature, and we'll come and, this is just a table which tells you what is the variation. So there are some countries where only a single dose has been recommended, and there are some countries which recommend 2 doses. And what is the rationale of antenatal anti-D? Now, the rationale of antenatal anti-D is that in countries where they have been able to do a full postpartum anti-D coverage, they found that there was still about 1 to 2% of babies which were being born, or they were still seeing 1 to 2% of isoimmunization. And therefore, this was happening because there were sensitizing events that were happening in the antenatal period that were undetected. And in order to cover this, antenatal anti-D came into vogue. And there are two types. One is a single dose of 300 microgram that is given at around 28 weeks. And then you have the US and Canada, where they recommend 2 doses at 28 weeks and then again at 34 weeks. And as you can see, there's a wide variation in the amount of dosing that is recommended by each of the country. Now, the rationale I told you is to reduce that 2%. So in countries where there isn't a very robust postnatal, postpartum anti-D program, the impact of antenatal anti-D is not going to be huge. So we are better served in ensuring that there is a robust postnatal anti-D program than investing the money on giving antenatal anti-D. And this is WHO stand. And this came out in the March of 2018, where they said that antenatal prophylaxis in non-sensitized Rh negative pregnant women at 28 and 24 weeks of gestation to prevent Rh alloimmunization is recommended only in the context of rigorous research. And this was their guidance for low and middle income countries, to which India belongs. So our focus really needs to be on ensuring postnatal anti-D. Of course, India is a land of contrast. We have large public hospitals and we have the posh private setups, and we have the private setups which are continuing to do care in 10 and 12 and 15 bedded centers. So we have a variety of healthcare. If we are able to, so we have women, in my practice, we don't routinely give antenatal anti-D, but we do have women who come and ask us about it. And if they do, we counsel them and give it to them. So like with any screening program, the actual impact of routine antenatal anti-D will come if we have a robust policy of postnatal anti-D. And I think that's the only point that I want to emphasize, that if we have given the antenatal anti-D, we still need to give the postnatal anti-D after checking the baby's blood group. So now moving on to a third scenario where you have a 36-year-old Rh negative woman. She's a gravida 6 para 2 with 3 miscarriages and 1 live child, which was born 5 years ago, after which she had anti-D. Subsequently, she's had 3 early miscarriages and an anti-D was not given. So now how should we plan her care? Clearly, here is somebody who we need to do the anti-D titer at booking, as in contrast to the primip who may not have needed it, and we may not be doing a big disservice if we didn't do it at that point. So in order to detect, we have to do the indirect Coombs test is what most of us normally do. And ideally, the ICT should come with a titer. Now, there are 2 types of tests. You have the gel test and the tube test. And tube tests are what are normally used to manage the pregnancy. Gel tests, they say there is more lab standardization. The titers are about 2 points higher than when you give a tube test, but there can be more discordancy unless it is standardized. Now, all of us have learned about the critical titer. The critical titer is a titer above which we expect to see isoimmunization, and traditionally these titers have been followed on a regular basis. And when you see the titer rising, then you refer for to see if the baby is isoimmunized. However, you can have a situation where the titer is below the critical titer and you can still have an alloimmunized fetus. You can also have a situation where the titer is high, but actually the fetus is not affected. Why would something like that happen? Because it has been shown that even if the baby is Rh negative, there can be something that triggers the mother's immune system to raise her antibody titer. And therefore, you could have a high titer and yet have a fetus which is not affected. So we are not going to treat the titer. The titer is only a guide for us to refer to see if the fetus is affected. Ultimately, we are going to begin treatment only if the baby is showing signs of anemia or hydrops. So the game changer came in the form of MCA PSV. And this was a seminal paper by Mari et al. Published in the New England Journal 20 years ago. And there they first showed, when they saw 111 fetuses with anemia, compared it with 265 normal fetuses, and they found 100% sensitivity for an MCA PSV that was greater than 1.5 mom, irrespective of whether the baby was hydropic or not. The false positive rate was 12%. I mean, that's a fantastic test to have to identify a fetus which is affected. So was this reproducible, or was it just something that Mari did as a one-off, and then subsequently people were not able to find out whether that same thing was happening or not? You have two meta-analyses that were done, one in 2009 and the other in 2019 actually, both of whom have shown that even in when you take the performance of the MCA PSV across many units. And the reason I'm quoting these two things is sometimes you have a procedure which does wonderfully well in the hands of an expert who has kind of honed his skills into ensuring that that's how this is done. Now, if somebody else performs the same test, does the test work just as well? That you get from these two papers, and you find that the sensitivity and specificity are pretty good, especially ranging from 75.5 specificity of 90%. So it's not 100%, but it's in the range of 80 to 90%, which is still extremely good. So today, if we want to find out if the baby of an Rh negative mother is anemic or not, we would rely on the MCA PSV. And given that you have so many trained sonologists and and obstetricians who can perform scans, doing an MCA PSV is not that challenging. So yes, we get the titers in the mother, but what is important is that we do the MCA PSV. So in this woman, at 22 weeks, her ICT was positive, a titer of 1 in 256. And and then she was referred for as an isoimmunized pregnancy. What we need to do is to look at her MCA, because the MCA is the one that will give you an indication of whether the baby is anemic or not. So the question of how often should we repeat the titers actually becomes redundant if you're going to follow the fetus with an MCA PSV. So if you have a titer, single titer that is raised, and you have the ability in your department or referring within your team to have an MCA PSV done, you can repeat the MCA PSV every 2 weeks to see whether the fetus is becoming anemic or not. However, if you are practicing in a remote location where you do not have access to the expertise to do an MCA PSV, and you don't want to send this woman traveling 400 kilometers or 100 kilometers to get an MCA PSV, then do the titers every 2 to 4 weeks. And if you start seeing an increasing titer, then you refer so that the MCA PSV can be done. And you refer to a fetal medicine. As I said, it is easier to follow with the MCA PSV. The other thing that has kind of changed or improved the the management of Rh disease is the ability to identify paternal zygosity. So and fetal DNA testing. About 40% of fetuses, I mean of us who are Rh negative, will be homozygous, which means that homozygous for the Rh negative gene, whereas 60% will be heterozygous. Now, cell-free fetal DNA can be done to identify the fetal Rh anti-D status if the father is heterozygous, because then there is a chance that the baby can be Rh negative or Rh positive. So unfortunately, in India, though we have NIPT available for aneuploidy screening, none of the labs are able to give us the fetal anti-D status. If they are able to, it would be a big boon, right? Because the sensitivity is extremely high, 99.3%, specificity is 98.4 for the first and second trimester. So if you did this and you knew that the baby is Rh negative, then really you don't need to worry about that pregnancy. Whereas if you did not know, then irrespective, all babies of Rh negative mothers will need to be screened for the potential development of fetal anemia, right? So besides the MCA PSV, there are other things that you need to look for, and you'll have to, so those signs would include a large placenta or placentomegaly. So when you do an ultrasound on an Rh negative fetus, it is not just the Doppler. There are B mode signs as well. So you would see a placentomegaly, you would see a hyperdynamic circulation in the portal venous system. So you can see an increase in the diameter. You would see, you don't expect to see a variation in the growth, but if it is a fetus which is starting to be affected by the anemia, then you can see cardiomegaly. And of course, in the worst case situation, you will see hydrops, which will be obvious as ascites or pericardial effusion, and a really sick baby will not be moving. So this is the MCA PSV graph, and you can see that the PSV is at about 56. Now, how do you know? I'm an obstetrician. I don't know how to interpret it. I don't have the software to tell me what this MCA PSV means. As a rough rule of thumb, your MCA PSV should not be more than 2 times the gestational age of that fetus. So if you're seeing a 22-weeker, if you see an MCA PSV that is greater than 44, then it means something that you need to refer. But there are normograms, and when you plot the MCA PSV in the normogram, it will tell you what you need to do. This is the normogram that is modified from Mari's original paper. And if you, this is the MCA PSV. This is actual value, not the mom value. And this is the gestational age. And when you plot it, you get the 4 zones, A, B, C, and D. If it is in the D zone, you just repeat it in 2 to 3 weeks. If it's in the C zone, you repeat the MCA PSV in 7 to 10 days. If it is in the B zone, in 5 to 7 days. And if it is in the A zone, it means the fetus is anemic and you need to actually transfuse. So you take the MCA PSV as per guideline and use the standard calculators to get the mom value for the MCA PSV for the gestational age. So are there calculators that are available? Yes, you have online calculators. This is the calculator from perinatology.com. You put in the gestational age, you put in the mean observed MCA PSV, and then you calculate, and then it will tell you what is the median peak systolic velocity for this age and what is your measurement in terms of a mom value. Now, the same thing is available from the Fetal Medicine Foundation website, where you can put in the gestational age, you can put in the MCA PSV. It actually will give you a fetal hemoglobin estimate as well. And on this graph, you can plot the MCA PSV and the fetal hemoglobin and know what is happening. Now, the Fetal Medicine Foundation website also guides the transfusion. When you do a transfusion, when you decide to do a transfusion, then this is the graph that you use based on the gestational age. When you begin a transfusion, you know what is the pre-transfusion HP, you put it down. You will know what is the hemoglobin of the donor bag, which you will put down. You will put down what is your desired post-transfusion HP, and that will tell you what is the volume that needs to be transfused. So all of this is made quite easy. And it is readily accessible literally at the click of a button. So this woman was followed, and at 27 weeks, The baby was about 1.1083 grams, 1 kilo and 83 grams. There was placentomegaly and hepatosplenomegaly. There was some right atrial enlargement. There was tricuspid regurgitation. The umbilical ductus venosus and cerebral CP ratios were normal, but the MCA PSV was 1.56 norm. So that is suggestive of fetal anemia, and because there were also suggestions of some cardiac overload, a transfusion would be planned. So when we are going to do the transfusion, what is the kind of blood that is used? You need O negative packed cells. These cells have to be washed and they have to be irradiated so that all the antibodies are removed from the packed cells. This means you need to have, the fetal medicine unit needs to have a tie-up with either a radiology department or an oncology department where irradiation of the packed cells can be done. Now, our normal hematocrit bags that we get, packed cells, that normal hematocrit in blood will be around 30-35%, whereas it needs to be at least double that because you want to reduce the volume that you're transfusing, right? So they need a high hematocrit. So it's spun to give you a high hematocrit. It's irradiated and washed. And then, as I said, the volume of transfusion is calculated based on the graph that I just showed you. So this again gives you the gestational age, and it tells you what is the blood volume of the fetus at that gestational age, and you can plot and see what is the so you have the fetal hematocrit here, you have the donor hematocrit there, and then you can actually figure out what is the volume that you're going to transfuse. Now the blood is cross-matched with maternal plasma. And again, this needs to be a lab which is used to doing this, because if you suddenly go to a different lab, they'll be wondering why you're cross-matching fetal blood with maternal plasma. It should be negative for antibodies. It should be fresh blood, less than 5 days old. And ideally, it should be CMV seronegative and has to be used within 24 hours of irradiation. Now, the process of intrauterine transfusion, basically, the transfusion is done. Usually, it's intravascular, which means the needle goes into the portal vein. You can see the spark of the needle, a white spot of the needle here, and into the intrahepatic portion of the portal vein, and then a transfusion is done. In the beginning, transfusions were done also intraperitoneally, but that is not ideal. You need to actually go into, and you need to go into the blood vessel intravascularly. Some people choose to do it in the cord, but it is sometimes difficult because in a free loop of cord, it can be floating and your needle can go through. Whereas here in the intrahepatic portion, it is more steady. And at least in Mediscan here, all the transfusions are done in the intrahepatic portion of the cord. So what happens once you do the transfusion? Once you do the transfusion, you know what the hemoglobin has come up to. Subsequent to that, we can follow the baby again by watching the MCA PSV. Now, when we do this, how sensitive is the MCA PSV beyond this point? I told you in the meta-analysis, they said that if you follow with the MCA PSV post-transfusion, it is still reflective of anemia, but it's not as accurate as pre-transfusion. So we need to know what will be the rate of fall. So you transfuse here, the hemoglobin goes up gradually. In 2 weeks' time, it will drop down. May need another transfusion to go up. Then again, it will drop down. Then again, it will go up. So till you reach a point in time where you want to actually deliver this baby safely. So post-transfusion, as I said, we still use the MCA PSV. And how do you time the next transfusion? The timing depends upon the rate of fall, right? So it is generally about 1 milligram per day. So usually if you have done a very good large volume transfusion, you can definitely be sure that the baby will not become anemic again for a period of 2 weeks, sometimes even 3 weeks. So some things that are important at the time of an intrauterine transfusion, the first time we transfuse, it is important that you document the fetal blood group. Now because many of us as obstetricians are not the ones doing the transfusion, this may get documented in the fetal medicine unit, but it is your responsibility to find out and document it on your antenatal case sheet so that the neonatologist knows what is the baby's original blood group. Because otherwise, the babies, we will not know, because once we start giving O negative blood, it will only be O negative when you take out the baby. So document the blood group at the first transfusion. Note down the pre and post transfusion hemoglobin, what is the volume, decide on the date of the next transfusion. As I said, from the final hematocrit of the last transfusion, about 1 per day is what it will reduce. And usually in about 3 weeks, you need to do the next transfusion. There are some people who do multiple small volume transfusions, but remember, each time you're going to poke the cord. So it is better to get a very high hematocrit blood and do a large volume transfusion. Now, once the fetus is transfused, when and how do we deliver? If the MCA PSV is more than 1.5 mom, you've reached a 35-week gestational age, then it is better to steroid and deliver, because most of the time the neonatologist will be able to manage outside, unless the baby is extremely anemic, in which case if you do a transfusion and deliver, the neonatal period will be that much less rough. In an IU, when the transfusion is being done, it is important that we try and time the last transfusion and time of delivery appropriately. By that I mean, if the last transfusion, let's say a transfusion is done at 31 weeks. In 3 weeks, this baby will still be just about 34, right? So you may end up having to give one more transfusion at around 34 weeks. And then you can push the delivery to about 36 so that the baby is as close to term as possible and still not become anemic. Because if you've given a transfusion at 33 weeks and then you want to deliver at 36, then you're already 3 weeks from the last transfusion, and this baby is going to be more anemic at birth than if it had got the transfusion at 34 weeks. So it's important that you liaise with the fetal medicine team and say, okay, if this is when you're going to transfuse, when do you anticipate the next transfusion, and then when am I going to deliver? If you're doing multiple transfusions, we know that with every intrauterine procedure, there is a risk of preterm labor. So sometimes if there is a transfusion around 33 weeks, we tend to steroid at that time, because if she goes into preterm labor for some reason, the steroids are taken cover of. It's important for us to prepare the couple for neonatal care and the costs of neonatal care, because there are couples who are willing to do everything as long as the baby is inside, because they don't anticipate still need an exchange after coming out, maybe preterm and require neonatal ventilation. And then the costs come into play, especially in the private sector. We can certainly deliver these babies vaginally as long as they are not anemic, they tolerate labor well, but you must have an experienced neonatologist at the time of delivery to resuscitate this baby. So this particular baby we delivered at 37 weeks after 3 transfusions, a 2.7 kilo baby, which did not need transfusions postnatally. So this is again just a rough guide, that if you use the MCA PSV as your guide, and if it's less than 1.5 mom, you just monitor. So you can begin at about 16 to 18 weeks and then keep monitoring. If the MCA PSV is more than 1.5 mom, gestational age is less than 35 weeks, then you do a cordocentesis check the hemoglobin, proceed with the transfusion. If it's more than 1.5 mom and she's more than 35 weeks, then if there's a tendency to increasing trend, then it's better to deliver after steroids. Now, what happens if somebody's had a previously affected pregnancy? Then you start screening even by 18 weeks. Before 18 weeks, it's difficult to do an MCA PSV. That's the reason. 16 weeks is about the earliest you can do it. So 16 to 18 weeks, you can do the MCA PSV. And by 18 weeks, you can start scanning. And then you use the same algorithm with the 1.5 mom. The neonatal care, you need a good neonatal facility. As I said, we need to liaise ahead of time. They sometimes they use, like, besides intensive phototherapy, they sometimes use immunoglobulin and hydration. They may do either an exchange or a double volume transfusion. The important thing to remember is that these babies can have marrow suppression. Because we have transfused them so many times in utero and we are giving them good hemoglobin, the marrow is suppressed. So it may take 3 to 6 months even before the marrow starts producing its own red blood cells. So we've had situations where these babies go and then get anemic after 3 months. And, especially if they are in small towns, then the neonatologists sometimes just send them back for a neonatal transfusion. So these are things that we need to be kind of watchful for. And as I said, because of the same marrow suppression, we may not know the fetal blood group for a good 3 to 6 months. So which is why it's important that that documentation is done. Yeah. And before I end, I just want to spend a moment for the mother, because these are mothers who need to have their blood group and grouped and cross-matched very carefully. If we get an atypical history and, where you have a history, let's say, where she's noted to be RH, no anti-DEET, ICT is negative, but there is a fetus which seems to have a hydrops, then you may have to do the full antigen antibody or red cell antigen profile to look for atypical RH, non-RH other antibodies. Now, whereas for herself also, she needs blood, that blood needs to be quickly available and quickly cross-matched. So in the UK, for example, they do a save and cross-match for a long period of time. And the mother's blood is a detailed antibody titer testing is done, and cross-match samples are kept available. And this is particularly necessary if they have had previous sections, and or if there's any other risk factor where you anticipate that they're going to need blood transfusion. So that is something that we cannot forget. So with that, I'm open to any questions that you may have, and thank you again for the opportunity.
Thank you so much, ma'am. There was some problem with my slide share, so I couldn't share your intro, the slide, ma'am.
That's okay, no problem. Yeah.
Ma'am, if our chairperson Nilesh sir permits, I would like to read out.
Sure.
Yes, definitely, Neha.
It's here. Dr. Umara, ma'am, DGO, DNB, FRCOG, FICOG, Director and Consultant OBGYN, Pethapathy Clinic and Hospital, Chennai. She is the Chairperson, South Zone, AICCRCOG, Examiner Part 3, MRCOG, Coordinator Part 2 and 3, MRCOG course, Chennai, 2003 to 2018. Contributed chapters in edited books and publications. Ma'am has Young Gynecologist Award 2007, AOFOG. She had IDF Blue Ring Women Achiever Award, Rotary International 2015. Her areas of interest are fetal growth, multiple pregnancy and fetoscopy, gestational diabetes mellitus, and health awareness in women. Her hobbies are music, travel, and reading. Thank you, ma'am. Sorry for not able to share it earlier.
No problem. These things happen. Not at all an issue. Yeah.
Now, I would like to request our chairperson, Dr. Nilesh Dalal sir, So please conclude the session, sir.
It was a very nice elusive talk by Dr. Uma, and the focus was on the soft markers along with the middle cerebral artery, which every gynecologist should know is an important non-invasive method to assess the fetal anemia. MCA and PCV is the standard, and the right focus was that after 3 weeks you repeat that test, and the importance of detection of fetal anemia. The right way to put the needle under ultrasound imaging in the porta hepatis, the portal vein, and not the intraperitoneal, which many centers still are doing for blood transfusion, is an important message. Again, the blood group of the neonate has to be done, she rightly focused, because once you are transfusing O negative blood, the blood group of that neonate has changed transiently, which will be reflected after some few months. The neonatologist facility is an important thing one should look for this high-risk pregnancy. I had many cases, Uma, of miscarriages where NTD was not given any time, and we could go for NTD, antenatal prophylaxis, and we got good results. So this is one of the things we had focused in that Gravida 6 para 0, 1, abortion 3, where this NTD estimation, the titer in the antenatal period and giving NTD antenatally can be of help. Because many times we get the patient from rural population subset. Many times they don't know the blood group for 2-3 deliveries also. And you rightly said blood group typing and matching. When you have any confusion, kindly take a third opinion from the laboratory, which is standard, before labeling the patient as negative. Because it occurs many times in a bulk of work like our government hospitals, where we have 40, 50, 60 deliveries in a day. Then it becomes difficult for many times the cards and all that being misplaced or mismatched. So this is very, very important for residents and postgraduates and all consultants to note. And we have a high-risk card system. We label it with red, the negative group on the antenatal card, so that we segregate such patients as high risk and negative. So they immediately, even if the nursing staff knows, no, she's a negative or one of the Rh negative patient, and the care will be taken of the cord blood sampling and hemoglobin, bilirubin being done at the time of delivery. And the ICT, the importance of ICT, you rightly focused the titration. Everything went very clear. I feel that 45 minutes on RH itself will sensitize our gynecologist obstetrician for this, an important high-risk complication, which we should prevent by giving proper NTD prophylaxis and few critical cases, selected cases for antenatal prophylaxis. Thank you very much.
Thank you.
Thank you, sir, for the enlightening words. As obvious, ma'am's talk was very elaborate and very self-explanatory. So I think there are no questions, but I personally have a lot of questions, ma'am.
Sure.
Ma'am, I would like to take these questions in short, like rapid fire sort of round.
Sure.
Okay.
First pregnancy, primi patient at 28 weeks. Do we need to give NTD prophylactically or not?
Yeah, so that's what I said. You can give, but the benefit is incurred only when everybody is covered postnatally appropriately. So if we are giving, what should we do? We need to check her anti-D titer. So check the titer, give the anti-D. After you give the anti-D, don't check the titer again, because you're giving her anti-D. Then if you do ICT, it will be positive. So you don't have to be panicking and then sending her for a, Doppler and all. So those are the points to remember with antenatal anti.
But
and
primi gravida
is just as good as 2. So you don't have to give twice.
So primi gravida, ANC, not necessary. Giving
Yes.
NTD
Yeah.
is not.
So that's what I said. By WHO, it is not necessary. The FOGC ICOG good practice guidance does ask us to give where it is possible at 28 weeks.
Ma'am, at 14 weeks?
14.
Yes, ma'am. 14 weeks.
14 weeks is only if there is a sensitizing event. Routinely, no. If she has bleeding, if she's going to have a CVS, then you give.
Ma'am, if the patient has bleeding or CVS, then so at any gestation we have to give, no?
Yes, yes.
And ma'am, dosage?
So I don't know about the availability of the
100 micrograms.
Here we don't get in Chennai, so we give 300 for everybody.
Madam, we are getting 150 microgram.
Yeah, so
you can give that. We can give.
You can give the 150. If you're getting it, you can give 150.
Husband and wife both are RH negative. Anything to be done?
So in general, no. In general, no. But I would test the baby's blood group anyway. In the West, and when we did our membership, we were always told treat an RH negative mother as if she has an RH positive baby, because you don't quite know who the partner is, whose baby it is. But we can't quite have that conversation openly with a lot of our mothers. So but you still need to check the baby's blood group, because if one of them is if both of them are heterozygous, you can still have an RH positive baby with both parents being labeled as RH negative. So don't forget to check the blood group. You may choose not to give the antenatal anti-D, but that's okay.
And embryonic gestation.
No need for anti-D.
If there was past history of abortion, any cause, MTP or spontaneous abortion, anything, but NTD was not given, then in this pregnancy, are we supposed to give it at 14 weeks or directly at 28 weeks?
I don't think there's any recommendation to give it at 14 weeks. You test for the titer. If she is already isoimmunized, there's no value in giving her anti-D antenatal. You just treat her as an isoimmunized pregnancy and monitor the fetus. If she's not had anti-D in the past, she's had miscarriage, whatever, you have tested her at booking, there is no anti-D. I mean, there's ICT is negative. You test her again around 20 weeks, ICT is negative. Then at 28 weeks, you can give her the antenatal anti-D. But you need to check her titers at least a couple of times, because if she's booking very early, let's say 6 weeks, 7 weeks, ICT is negative, you would need to check at least one more time in between.
Okay. Ma'am, if blood transfusion is given to a RH negative lady, is it required to give her NTD?
No, you just need to transfuse the appropriate blood.
Yes, that is done, ma'am.
Yeah, no need to. No need to.
Pregnancy with jaundice?
Sorry?
Pregnancy with jaundice.
Okay.
Is there any role of NTD?
No.
Jaundice per se, if
for the mother?
Yes, ma'am.
No need to give.
Maternal jaundice I'm talking about.
No need.
Ma'am, is RH negative pregnancy a high-risk pregnancy?
It has the potential to become a high-risk pregnancy. Just because a woman is RH negative, she's not a high-risk pregnancy. But if she develops isoimmunization, she becomes a high-risk pregnancy.
So any consent to be taken?
So according to the British Hematological Society guidance, when we give anti-D, we have to get a consent signed. In actual practice, we don't do it. I don't know about what Dr.
Uma, I'll make a point here. For all entities, even in private, in the clinic or in the hospital, we are taking a consent in the form that we are given the injection, like you rightly said in your talk, and the time and the date of administration. Because it is very important. Many times the injection is so expensive, it's not many times hospital supply and the patient has to buy from outside. फिर कई बार अपने कंप्लेन आती है कि देखो सर हमको तो इंजेक्शन ही नहीं लगा है. So we made a protocol that any time the NTD being given, the date and the time being mentioned by the doctor and the nursing staff, so that it's in the document which day, 72 hours or less postpartum mostly, and it is safe for us for medical legal reasons also.
Yes.
So it is very important that we take it in black and white.
Very true. We document, Dr. Dalal. I was asking whether you get a consent sign.
That many times we are getting, because not all, yes, we are getting it. Because sometimes like some reaction or something, we don't know.
We don't.
Just 2 lines, yes, 2 lines.
That's a good practice actually. The other thing we have started doing in the last few years is even when we give a Tdap or
Yes.
vaccine, we
Then
take
also.
a sticker and put it onto their card, just
Yes,
like the
yes, card.
pediatricians do, so that we can say कि इधर है ना हमने दिया आपको.
Yeah,
Otherwise
yes.
they forget.
Forget. Very right.
Yeah.
Thank you, ma'am. Thank you, sir.
Thank you. It was a nice discussion.
The house is open for questions by all, if anyone is interested. Ma'am, I just had one more query. I think I missed the thing or I didn't hear it properly. You said if there is painless bleeding, then we don't have to give NTD, and if there is painful bleeding, then we have to give NTD.
That is in early pregnancy, very early pregnancy. If there is, because like you asked if it's anembryonic. Now suppose somebody comes at 6 weeks and just little spotting, the recommendation by most of the guidelines is it's okay not to give anti-D because actually the hemopoietic system has not yet developed. But the problem with that is if you think that, you know, in the implementation there can be confusion, that, you know, maybe the nurse or the junior doctor doesn't get the gestational age right, and there's a chance that she may actually be 9 weeks with a viable fetus. You could just have a standard protocol that any point where she comes in bleeding, you give her the anti-D. That is safer. But if you can individualize, then in the very early gestations, because the hematopoietic system is not yet developed, you could get away without giving anti-D. And that is because of the cost.
No questions? Sunita ma'am?
Everything is clearly said.
Thank you.
Then, as expected.
Thank you so much, ma'am.
As expected, it was a wonderful knowledge session, for which I, Dr. Neha Saraf, with our president, Dr. Manisha Maheshwari ma'am, on behalf of Ratlam ROGS and Gynae Society, would like to thank our guest speaker, Dr. Uma Ram ma'am, for discussing every minute detail thing in detail. Thank you, ma'am, for sparing your time for Ratlam Society. Thank you for all the knowledge shared. I, with folded hands, thank our chairperson, Dr. Nilesh Dalal sir, for sparing time out of his very busy schedule. I also want to wholeheartedly thank my Ratlam Society family and all other Foxians for attending and making this webinar a success. Lastly, I thank Team Pharmacin for all their support. Thank you, everyone.
Thanks a lot.
Hope to see you soon, ma'am, sir. Thank you.
Thank you, sir. Thank you, ma'am.
Take care.
Thank you, everyone.
Bye. Thank you, Mr. Dal.
Thank you.
Thank you, Mr. Arjun.